Hi, everyone. It's really a pleasure for me today to present the cardiopulmonary assessment and diagnostic approach in the context of the Dr. Regan Giesinger clinical cardiopulmonary physiology for the care of the sick newborn. Really, it's truly an honor, especially knowing that Dr. Giesinger was one of the pioneers in the field of hemodynamics, and especially in the context of babies with hypoxic-ischemic encephalopathy. So I do make available here QR codes if you want to get access to these slides. I don't have any conflict of interest to disclose regarding this presentation, except that obviously this current presentation is based on my own experience, knowledge, and interpretation of the literature, and that many of the medications presented in this presentation have not been tested in the context of RCTs targeting the newborn. And so the objectives today will be to review some of the physical cardiopulmonary assessments, evaluating common derangements in HIE. We'll go over some of the difficulties of interpreting the hemodynamic biomarkers of circulatory failures in infants with perinatal asphyxia. We'll speak a bit about some of the physiological rationale to cardiovascular support in the context of right heart failure for patients with HIE, and we'll decipher some of the early associations between early postnatal ventricular dysfunction and outcomes among infants with HIE. So we'll start with the first objective. I just want to point out, as I mentioned, that it's really an honor and privilege to be able to give this talk, and I really want to dedicate it to Dr. Regan Elizabeth Giesinger, who published many of the landmark articles on the subject, which guides numerous clinicians across the world, including myself, for the management of these fragile newborns. Here are some of her many publications regarding this particular topic, but she has touched every single topic of neonatal hemodynamics. And one of her really sentinel papers is the one where she looks at the hemodynamics perspective in the context of HIE and therapeutic hyperthermia. And I think she really cornered some of the key principles of physiological elements we need to keep in mind when addressing some of these babies at the bedside. And I think this figure is one of the great ones which outline the effect of the primary insult on the heart, on the pulmonary vasculature, and on end organs, as well as the effect of hypothermia and eventually rewarming in the both ischemic and reperfusion injury that may happen in some of these patients, because what we're trying to promote in these babies is early and efficient recovery of their brain. And so many of the theoretical components are within this paper, and I'll actually outline some of the mechanistic pathways that Dr. Giesinger has brought up. One of them is this beautiful table that we will actually use all throughout the talk, which outlines some of the physiological phenotypes that we may see in some of our babies. And these phenotypes may shift throughout the hospitalization of these patients and with interventions that we're doing, especially if there are seizures or anti-epileptic medications that are introduced in the management of these babies. And I think, this little card should be in the pockets of every clinician and every fellows in hemodynamics or neonatology in order to help guide therapy. And so we know the hypoxic event can affect multiple organs, the brain and the heart being some of the key ones that may really further alter the outcomes of these patients. But it can affect the lungs, the pulmonary vascular transition, the liver. You can get anemia, coagulopathy, bleeding, the kidneys with acute kidney injury, or you can have eventually some SIADH. You can have intestinal issues and inflammatory reactions. And obviously, the muscular ischemia can lead to CK release, which can cause further kidney injury. And so I'll start with this case, which is a baby born a bit post-term with meconium-stained fluid and prolonged decelerations, going for a stat C-section, baby flat at birth, intubated with resuscitation in the delivery room, and a core pH outlining some significant metabolic acidosis. On physical exam, the neurological status is compatible with moderate encephalopathy, and the baby is initiated on therapeutic hypothermia, which we know may also potentially further exacerbate pulmonary vascular resistances. The X-ray is compatible with oligemia, and in the first 10 hours, the baby is found to be hypoxic with high-frequency settings on the ventilator that are relatively high. And despite that, and with adequate CO2 clearance, we remain with some degree of metabolic acidosis and a PO2 via the umbilical arterial line, so postductally, that is quite low. We're on mean airway pressure around 10 with FiO2 around 80%. And we have pre-sat of 80% and postductal sat of 50%, with blood pressure that are a bit borderline via the art line with prolonged capillary refill time. The liver is at 3 centimeters on the exam. The hemoglobin is relatively okay. And so if we go with our first objective is to outline what could be some of the variables that we would look at in terms of our hemodynamic parameters in these patients. And so we'll go over some of them and some of the caveats related to that. So we need to understand the difficulties of interpreting some of these biomarkers at the bedside of circulatory failure. And so when we look at these patients, if we go back to the table that Dr. Giesinger has brought up to us, there's obviously the common vital signs that we're going to look at. So the blood pressure, the heart rate, obviously saturation, respiratory rate will provide you some information. I think BP, we need to have all the components. So this is systolic, the diastolic, the mean. Look at which areas are we taking this blood pressure, which method are we using? So, is it arterial versus is by cuff BP in the pre or postductal area? But really, blood pressure are just in absolute numbers, and we know that BP is actually a function of flow and resistance. And so, you may be able to maintain some degree of blood pressure within what we would consider normal range, but you may have very, very high SVR and decreased flow to your organs. And so trends are important, but absolute numbers sometimes will not tell you the whole story. Heart rate is very difficult to interpret in some of these babies. We know that, when they have autonomic nervous system anomalies, their heart rate may be all over the place, either bradycardic or even sometimes the heart rate may be completely normal and flat without variability. And that might not be, telling us if it's reacting appropriately to the underlying physiological derangements. We also know that TH will impact heart rate. And so sometimes it's a bit more difficult to interpret. And again, trends will provide potentially more information if the autonomic nervous system is integral. The capillary refill time often by default will be prolonged because of the hypothermia. And so obviously assessing your patient at bedside multiple times will provide potentially more information, but it's definitely not providing you the whole story on that. Pulses and physical exam, liver edge could sometimes provide you some information. So central pulses may be sometimes diminished in the context of poor output, but it can also be very difficult to figure out if your baby's already puffy or edematous in the context of some degree of acute kidney injury. Liver edge may be increased, but it could also be a sign of high mean airway pressure on the ventilator, but sometimes can be a sign of increased end-diastolic pressure in your right ventricle. And finally, cold to touch, well, you'll be cold because you're on therapeutic hypothermia, so it's not the best marker of hypoperfusion, such as also being modeled. When looking at other things like alteration level of consciousness, where it's going to be very difficult because our babies, by definition, with HIE and moderate to severe encephalopathy will have alteration level of consciousness, but changes or fluctuation in the level of consciousness may be something that could be a marker of alarm. Urine output is often very confounded by the primary kidney insult, as well as sometimes component of SIADH. And finally, the lactate, or as one of the main biomarkers, or acidosis, will be typically high and will often persist to be high at the beginning of the hospitalization because there's been retention in tissue and often decreased clearance by the kidneys. And often you'll start seeing blips if your baby has seizures because it's consuming just so much oxygen and relying on the anaerobic activation for energy production. So it may not be the best marker of an organ perfusion. It's really by using a constellation of the markers, being at the bedside constantly, and the trends within time of one patient, as well as the response to your management, that you're going to get the best evidence of end organ perfusion. And this is where I bring my own pitch, where I do think that bedside targeted neonatal echocardiography and hemodynamics really provides you a lot of information about presence of function and output, shunt direction, pulmonary pressure. It allows you for the follow-up of these patients, titration of therapy, and assessment of response. And also, you may be able to find things that you don't expect, like an effusion or sometimes a congenital heart defect that you will need to have your cardiologist involved for. So let's go with some of the physiological rationale to cardiovascular support in the context of these neonates. Again, I bring back to this table and we'll go through some phenotypes. The first one is the classical one of what we call PPHN, or acute pulmonary hypertension due to high pulmonary vascular resistance. Typically in this context, you're going to have persistence of, high PVR relative to SVR, which leads to right to left shunting at the ductal level, introducing hypoxic blood in the descending aorta, hence why often the PO2 will be very low. Because of that, you get less pulmonary blood flow, your lungs look quite black, you have less pulmonary blood flow filling your left atrium, and you have, this will favor a right to left shunt at the atrial level, which makes you pre-ductally desaturated. And obviously this is favored by the fact that often the RV is facing higher afterload, which will end up in slightly higher end-diastolic pressure and slightly higher RE pressure relative to the LE pressure. And this allows you to maintain some degree of output because your LE filling is highly dependent on the right to left shunt at the atrial level. So these patients will all have often pre-ductal desaturation plus or minus, some degree of SAT differential if the PDA is open. So it often looks like this. So you get right to left shunting at the ductal level and right to left shunting at your subcostal view in your interatrial shunt. These patients may have preserved cardiac function to some degree because the PDA is still open. They'll have signs often of high PVR, such as a high PAT on RVT ratio, and they may have, either isosystemic to slightly suprasystemic RV pressure. But if the PDA is widely open, they'll typically have isosystemic PA pressure because of the equalization of pressure across the duct. So what we would do in these contexts is often tackle the fact that the pulmonary vasoconstriction is significant. So we would optimize ventilation, make sure we provide some degree of sedation just to avoid hyperreactivity of the lungs. And often we'll introduce INO if the optimization of the ventilation oxygenation is not adequate. And some of these babies may require to have the addition of either norepinephrine or vasopressin as one of the agents that will improve the PVR to SVR ratio. And as the PDA becomes restrictive, we start thinking about PGE. So that's an example of when the PDA becomes restrictive, where you start having this issue of not being able to equalize your pressure, and then your RV faces increasing afterload. So these patients may not have a high shunt volume at the level of the PDA, and so your saturation may not be that different than the one in the preductal space. And at that point, you get a much higher volume of hypoxic blood that may enter your atrial level, and eventually your RV starts failing. So often these patients have, struggling RV, they have, suprasystemic PE pressures, and eventually, you get flattening or bowing of your septum, and you see these PDAs that are becoming much smaller with suprasystemic right to left components. And so in these contexts where you start seeing that the RV is struggling, you obviously want to more, as you try to decrease your PVR, you want to try to promote inotropy. So dobutamine might be a good option to provide some RV support. And at this point, if your baby is still not responding well to the therapy, we would initiate maybe consideration for PGE, for example, plus or minus hydrocortisone to support adrenal function if we think there is some degree of adrenal suppression. You may have some of these patients with component of RV failure and PVR where there's also a component or significant component of the LV failure. At this point, if the LV failure is very significant to the point that you have decreased LV output, these patients will have high LV and diastolic pressure, which will back up into the LA. And so often these patients will have actually a left to right shunt at the atrial level, and they will often saturate greatly at the level of the preductal limbs, especially if you don't have any ventilation perfusion mismatch at the level of the lungs. So obviously if you have a meconium aspiration syndrome where there is VQ mismatch, you will have hypoxic preductal limb saturation because your pulmonary venous saturation is lower than expected. But if you do not have that, you may have just a little bit of blood flow coming back to your LA that is within normal limit in terms of saturation, and will shine into the right atrium because the LV and diastolic pressure is so high considering the LV failure. And at that point, your right to left shunt at the atrial level is essential to promote the actual systemic circulation flow. And so while there might still be a component of high PVR, you're highly dependent on this right to left shunt to provide blood flow to your system, and your PD is quite important in this context. So these are situations like this where your LV is quite depressed in terms of function, and often your LA pressure is much higher than your RE pressure, so you get a left to right shunt at this level. But despite that, you get a right to left shunt at the PDA level, which will feed your systemic circulation in terms of maintaining the output. And so in these particular contexts where you see much depressed LV function, and sometimes you may have some degree of component of RV dysfunction, you will obviously want to act on your inotropy. And so INO is not necessarily part of that because you don't want to have a steal effect from your systemic circulation. And what you want is really promote the cardiac function and maintain your duct open if it becomes restrictive. And so dobutamine or epinephrine are kind of good agent to think about in these contexts. And as I mentioned, you can have various degree of either isolated LV dysfunction or biventricular dysfunction, such as in this case, where you see that the RV looks dilated in the parasternal long axis view, you have diminished TAPSE, RV-LV function is quite diminished. And in this particular case, you see a bidirectional duct, bidirectional PFO. And where you get, profoundly decreased also RV function and, really a struggling RV and LV in the parasternal short axis view. And in that context, in this particular view, we had even decreased cerebral vascular velocities of flow. So this particular patient has profoundly decreased LVO and RVO, less than 150 cc per kilo per minute, is desaturated everywhere with pre and post ductal, saturations that are similar because of the bidirectional shunt at each level. And so in that context, you really want to focus on your inotropy, so dobutamine or epinephrine, if it's really significant. Obviously take into account that epinephrine may also cause a rise in your lactate levels in your blood in some of these patients. And sometimes you have situations that are so critical with so profound decrease in function that you may start your process of supporting this RV and LV's function, but some of these babies may either require ECMO or consideration of stopping TH if necessary in some of these patients. But that is obviously outside of the scope of this presentation. And there's many, many variations, smaller no PFO, duct becoming restrictive, concomitant seizures, which may affect your autonomic nervous system, the effect of anti-epileptic medications, which are often profoundly vasodilating. You can have concomitant underfilling if the patient had some bleed, like in placenta previa or abruption. And sometimes you have concomitant parenchymal lung disease, which can confound the picture and may need high meninary pressure, which can impact your right atrial and left atrial filling depending on the context. So in our case, a TNE was requested. There was flattening, bowing of the septum with RV dilatation. And we had a right to left shunt at the ductal level. We had decreased RV function with TAPSE of 5 millimeter and FAC of 25%, and some degree of suprasystemic RV systolic pressure with right to left shunt at the atrial level. So we applied the algorithm that Dr. Giesinger provided us. We started dobutamine, started INO, and immediately the saturation improved and the blood pressure improved in this patient. And you can even see that as we're doing the echo and introducing the therapy, within minutes, we had improvement of the RV function by TAPSE. And so that's exactly the approach we had in this particular patient. So I do provide here kind of my own cheat sheet of the different medications and their effect on SVR and inotropy. As well as a beautiful graph that's from Dr. Satyan regarding some of the pathways for pulmonary vasodilation. The last part of the presentation is really to speak about some of why it's important and the early association between early and postnatal ventricular dysfunction and outcomes in these patients. So why do you think it's important? Well, obviously, when we look at some of the Cochrane review and INO initial studies, we see that there's a drop in death or use of ECMO if we address the component of high PVR in some of these patients with hypoxic rest failure. But it also tends to improve in the survival the outcome of neurodevelopmental assessments and at least by the Bailey scores when you address some of these acute PH situations. And so one of the key hallmark paper by Dr. Giesinger is this prospective study that was done in Toronto, where RV dysfunction was actually associated with the risk of death or brain injury by MRI, outlining that there might be a component of cardiac disease that potentially could be addressable in some of these patients to promote their brain recovery. And we found pretty, identical findings in a retrospective cohort that we analyzed when I was at Stanford, where actually RV dysfunction as well as LV dysfunction were associated with the adverse outcome of mortality or brain injury by MRI in these patients. And so while this might be a marker of severity, it opens the door to the idea that if we would provide more tailored therapy to these patients and try to reestablish some homeostasis, we could potentially improve further their outcomes. We recently looked at our own cohort at McGill, and we found that LV dysfunction, as quantified by 3D echo, as well as markers of septal flattening using circumferential strain, were associated, again, with the outcome of mortality or brain injury, outlining that there may be a component that is primarily driven by the heart in some of these patients. And so I do think that the neonatal diagnosis of shock in neonates is difficult to establish in the context of TH and HIE. And this is where TNE and neonatal hemodynamics may help you at bedside to provide tailored therapy. And so every case does need to be evaluated thoroughly. And I do think that, the consideration for echo to provide better guided care when starting, adjusting, especially weaning some of these medications which may have brain side effects is quite important. In acute PH, I think, inhaled nitric oxide is one of the medications that we have that can promote recovery, as well as some of the other elements like optimization of ventilation, calm environment, sedation to be optimization, and the acid-base balance, PG to be considered. We spoke a bit about the fact that vasopressors should be used, especially in some of these cases of acute PH, but also when there's vasomotor dysregulation or use of anti-epileptic medication, which may increase your systemic vasodilation. Inotropic support is often key in some of these patients because they could have myocardial dysfunction. PG can be your friend to pop off in certain situations, and obviously, treatment of seizure will be important because it induces reactivity of the pulmonary vascular bed and increases your lactate. Finally, I want to remind you about this table and keep it in your pocket, especially when you're at night and you're facing some of these situations. Thank you very much for this invitation, and I'm very happy to take any comments during the comment and question section.